Okay, so hi everyone. My name is Juliette Camejo. I'm excited to present our case titled The Myelin Games, MS versus NMO, in collaboration with my colleagues, Luiza, and then Dr. Jorge Diaz and Yeissen Godinez from HCA Kendall Hospital. So I come from NSU MD program in South Florida, in Davie. So let's begin with a bit of background. So both MS, multiple sclerosis, and neuromyelitis optica, NMO, are autoimmune demyelinating diseases of the central nervous system. They share overlapping features, which makes diagnostics particularly challenging because MS typically presents with unilateral optic neuritis, partial myelitis, and sensory symptoms, and it's diagnosed by dissemination of the symptoms in space and time. NMO, on the other hand, is associated with aquaporin 4 antibodies, which target astrocytes rather than oligodendrocytes. It often presents with severe bilateral optic neuritis and longitudinal extensive transverse myelitis. And diagnosis basically hinges on the specific MRI findings and a serological detection of the aquaporin 4 IgG antibodies. So our patient is a 37-year-old female. She has a history of recurrent migraines and anemia. She presented with altered sensation, describing alternating warm and cold feelings and decreased sensation in the right lower extremity, the right back, and the left hand. Interestingly, she had experienced a similar episode 6 years prior involving bilateral lower extremity numbness that had eventually resolved on its own. At that time, the brain MRI that she had revealed nonspecific lesions, but no official diagnosis was ever made. So in this visit, when she presented a couple of months back, her physical exam showed sensation loss in the right L2 to L5 dermatome compared to the left side. When we did imaging, it revealed a longitudinal extensive lesion from C4 to C7 on cervical MRI, which in figure 1, you will see that right there, this longitudinal lesion that expands 2 vertebrae. And then also at the same time, we saw a punctate T2 hypersensitivity in the left posterior white matter on the brain MRI, which is figure number 2. So the lumbar puncture that we did showed elevated protein and glucose, but it was negative for both oligoclonal bands and aquaporin 4 IgG antibodies. So at this point, we weren't sure if it was MS or NMO. So given the concern for a demyelinating process, which is something that we were sure of, we started her on 1 gram of IV prednisone for 3 days at the hospital, and her symptoms did end up resolving. So the images show that. If anybody has any questions later on, we can go over the images. So the case highlights the diagnostic dilemma when a patient presents with overlapping features of MS and NMO. Both can present with myelitis and nonspecific white matter changes, making it hard to differentiate it, especially in the early stages, and especially when both aquaporin 4 IgG antibodies and the oligoclonal bands on the CSF are negative, as was our case here. It's important to recognize that mistreatment can cause harm. For example, interferon beta and natalizumab, which are therapies for multiple sclerosis, have been shown to actually worsen NMO, possibly due to enhanced astrocyte damage. And conversely, treatments for NMO like rituximab or azathioprine may not be effective in preventing MS relapses. In cases where the diagnosis is uncertain, as in our case, it's important to start with empirical corticosteroid therapy, and it offers a safe bridge to treatment while you do further diagnostic data. So ultimately, after the patient was discharged, she was fine. She followed up with neurology and did repeat testing, and she was diagnosed with relapsing remitting MS. She later also experienced another flare, which was quickly resolved with a course of dexamethasone. And the last thing we heard is that she is now beginning treatment with ofatumumab, which is a monoclonal antibody that targets CD20 expressing B cells. It's one of the newer treatments for MS. So she's starting treatment with that, and hopefully everything can stay under control for her. So this case emphasizes the importance of early clinical suspicion, timely imaging, safe empiric treatment, and a close neurological follow-up to guide the evolving diagnosis and avoid potential harmful therapies, because both of the demyelinating diseases are very similar. So thank you for your attention, everybody, and I'll be happy to answer any questions.
Yeah, that's a very nice presentation. Let me ask you a question. You have that MRI. You see that of the neck where the lesion is?
Yeah.
What's your thoughts about the position of the neck bones? Does that look normal to you?
No, so
Yeah. So what's the pathology? It's not normal. So what's the pathology? I'm talking about the bones now. I'm not talking about. Yes, that's what I'm talking about. See, look at this. Here's a real problem. She's lost her lordosis. That lordosis, that's severe. That's a real problem. And the question you have to ask is, and if you actually look for her age, if you start looking at the facets, she's starting to develop at her early age some arthritis. So the whole question comes up, when you're losing that, you get some inflammation. It can then cause issues with the spinal cord. And the whole thing, because I'm finding with the ENT plastic surgery, I've been looking into all this stuff. It all comes up. And the whole point is you have the physical factors, but also you have the image factors, the immunological factors, and you have to kind of piece it all together. So I think, like for her, for example, some physiotherapy would help her. And then the other thing to actually look in the past when she had these symptoms, what was the story? Also, what's actually triggered this? Is there something that triggered the inflammation at this time recently? These are just issues that I'm just mentioning. I'm fascinated by this presentation.
Yeah, so she was actually my patient, my team's patient while I was doing my internal medicine
Yeah.
when I was an M3, and nothing specific triggered her. It came out of nowhere, where she was having this loss of sensation in one of her legs, and then she had this feeling of warmth, where at one point she actually thought that she had peed herself, because she felt like a warmth feeling, but when she checked, there was nothing. It was very, very strange, and the symptoms.
So what was her activity? Was she waking up and was she working? Did she have kids? Was she getting around, exercise?
She has kids. She was working. I'm not too sure about how much exercise she does, but everything pointed out to be that there was no trigger that we found.
Oh, okay.
Yeah, and because of her previous, when she did mention like 6 years ago, I had an episode of a similar feeling. I had some MRI done, but she never got fully diagnosed. And she resolved and had no symptoms for 6 years, and then showed up to the hospital with the new symptoms. And it quickly resolved with like the first day of steroid treatment. She was already feeling way better. Her sensation was fully back. So yeah, it does make us think whether it was both a conjuncture of the MS and also the problems with her spine and arthritis, or it was just the MS.
Oh yeah, well you can have that because it causes inflammation. See, that's the point. See, MS is an inflammation by one mechanism, but inflammation can have other mechanisms.
Exactly.
Yeah, very nice.
Yeah.
Thank you very much.
Thank you.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.